eTEP stands for Extended View Totally Extraperitoneal Ventral Hernia Repair. The technique, first described by Jorge Diaz for inguinal hernia repair and then popularized by Belyansky and colleagues for robotic ventral hernia repair, mimics the open Rives-Stoppa technique in both indications, inclusive of primary incisional and recurrent ventral hernias, and the placement of the mesh between the rectus muscle and the posterior sheath, also known as the retrorectus space. The eTEP procedure was conceived and is increasingly adopted because of the advantages inherent in the procedure. As the eTEP name implies, this technique affords the surgeon the opportunity to remain extraperitoneal throughout the entirety of the case. From a durability perspective, eTEP has been shown in early studies to be just as efficacious as an open technique. This similar result in durability is accompanied by other advantages unique to the approach. Minimal mesh fixation is required, thus reducing the likelihood that historical means of fixation contribute to cases of chronic pain. eTEP also eliminates any contact between bowel and mesh, as there is no entry into the abdomen or placement of intraperitoneal mesh, and elimination of peritoneal or midline fascial defects decreases future hernia risk. Previous studies have suggested other advantages in outcomes as well, including decreased OR times, overall costs, complications, as well as decreased lengths of stay compared to the open procedure. Decreased narcotic use and faster return to normal activity has also been observed. Key steps listed here will be reviewed in detail throughout the remainder of this presentation. Details regarding the steps will be accompanied by tips for each portion as well as some common pitfalls. Case preparation and setup is key in both ensuring access to equipment that optimizes the procedure as well as ensuring cost containment by limiting the opening of unnecessary instruments. Back table setup is seen here. While access to the retrorectus plane can be achieved with any trocar, we use a key Fios trocar produced by Applied Medical. The advantage of this device is that the insufflation port is 3 mm from the tip of the obturator, allowing for CO2 insufflation to perform initial dissection of the retrorectus space. Patient positioning is also tantamount in procedure optimization. The goal is to maximize distance between the ASIS and the costal margin, thus maximizing the retrorectus space. Ultrasound is then used to identify key anatomic landmarks in procedure planning. The goal is to place trocars at the lateral edge of the rectus sheath to gain access to the retrorectus space. Preoperative identification and marking of landmarks enables correct procedure initiation and access to the appropriate anatomic plane. Entering too lateral through the linea semilunaris or through the obliques bypasses the retrorectus space and enters the intra-abdominal space. If too medial, however, there will not be adequate working space. In the case of intra-abdominal insufflation, a 5 mm port or varus needle placed intraperitoneal allows for desufflation of the abdomen. Seen here is the preoperative marking of anatomic landmarks and planned approach for either a side dock or top-down approach. The top-down approach will be demonstrated in the procedure video, but each is acceptable for the robotic eTEP procedure. Bilateral transversus abdominis plane or TAP blocks and often rectus sheath blocks are placed prior to the procedure. Again, careful identification via ultrasound of the planes of the abdominal wall ensure patient safety and optimal anesthetic effect. The procedure begins with obtaining access to the retrorectus space at the aforementioned lateral aspect of the rectus sheath at an angle that limits the potential for inadvertent entry into the obliques or intra-abdominal space. The rectus muscle is visualized and insufflation is initiated at 15 mm of mercury. Once the posterior sheath is identified, the angle of the camera and trocar is flattened, and the trocar is advanced under direct visualization. Initial dissection of this space can occur bluntly with a laparoscopic camera. Neurovascular bundles are maintained anterior to the plane of dissection where possible. Be sure to reflect rectorectus fat toward rectus muscle. This will help avoid injury to the inferior epigastrix as the plane is developed toward the pelvis. A finder needle is then used to identify location and angle of entry for the second port, which is placed about 6 to 8 centimeters or about 1 hand's breadth inferior to the initial port site and again along the lateral aspect of the rectus sheath. Additional development of the plane is carried out using hook cautery, and any bridging vessels between the rectus muscle and the posterior sheath are cauterized. To begin the crossover process, the medial aspect of the posterior sheath is incised near its insertion into the rectus muscle. This enters the preperitoneal fat plane. In low BMI patients, the lack of significant preperitoneal fat may make this plane difficult to maintain, and violation of the peritoneum is more common. The preperitoneal space is developed laterally until the rectus muscle can be visualized through the posterior sheath on the contralateral side. This is identified by the salmon-colored hue that will show lateral to the white midline and/or diastasis if it exists. Developing the preperitoneal plane too laterally, however, runs the risk of violating the peritoneum as the fat plane thins out laterally and the peritoneum becomes thinner as well. A port is placed in the epigastric region off midline and through the rectus muscle, while another is inserted as lateral as possible while still in the rectus sheath on the contralateral side of the initial access port. Port placement through midline or diastasis increases the risk of future hernia formation. The robot is then docked as demonstrated here using one of two approaches. We prefer to maintain laparoscopic visualization of robotic camera and instrument insertion to ensure no injury upon entry and to optimally position instruments during the docking process. The midline is further released in a top-down approach while maintaining integrity of the peritoneum. Avoid entering hernia sac if possible as the midline is taken down. This may be difficult to achieve if there are dense adhesions or adherence to previously placed mesh. Not knowing or directly visualizing what is behind the posterior sheath or reckless entry into the intraperitoneal cavity can easily lead to bowel injury. Note the tenting of the arcuate line serving as an additional anatomic landmark as dissection proceeds toward the pelvis. Hernia contents are reduced as adhesions to the hernia sac are carefully dissected away. During this process, it is common for there to be violation of the peritoneum, especially if prior mesh was placed intraperitoneal. In this case, carefully lyse any adhesions between bowel and mesh prior to mesh excision. Avoid, however, over-dissecting inferiorly beyond where you desire mesh to be placed. Previously placed mesh is carefully excised. The mesh can be cut into a pinwheel shape to facilitate removal through a trocar. Attention is then turned to closing the posterior sheath and peritoneum to allow a layer between the bowel and where the mesh will be placed. If there is trouble bringing the posterior layer together, a unilateral or bilateral TAR, or transversus abdominis release, can be performed. If that does not create enough laxity, then a patch can be fashioned out of the falciform ligament, the omentum, or an absorbable mesh. Next, attention is turned to closing the anterior hernia defect. Reducing the insufflation pressure will likely help in closure. However, watch for dislodging of trocars with desufflation. A lightweight, macroporous, soft mesh is then prepared for insertion into the developed retrorectus plane, which is measured for appropriate mesh size. Accurate measurement is paramount, as too small a mesh will provide inadequate defect coverage, too large will cause bunching that can lead to suboptimal cosmetic outcomes, increased pain, and infection risk. Attention is paid to even distribution of the mesh and complete coverage of the developed plane. The space is desufflated and port sites are closed.